Now we are forward to the debate. And first of all, I would like to ask for panelists the hopes and hypes and the hypes attack the hopes.
Let-
You want to attack?
I think I,
Oh, you want to
yeah.
attack? Okay.
So let me just clarify a couple of points that my friend and colleague, Dr. Soper, brought forward. First of all, in terms of the state support, 6% and going down for our medical center. So we are called the University of California, but at this point, I'm pretty sure we're paying more in administrative burden than 6%. So we're essentially, we do get a little bit of state money, but that shouldn't stop us from moving technology forward. Second, I think this is a really important point. Just like many of the technologies we're talking about are advancing, so is our ability and set of tools to answer questions. We have for decades said that the prospective randomized trial is the way we answer questions. But we now know there are many questions that are not going to get answered that way. And I can tell you, if we wait for a randomized prospective multi-center trial to try to answer questions about robotics, we're going to be waiting a very long time. That and many other questions are going to need to be answered using outcomes tools with large databases, which is what we've begun to try to do. So, you know, the randomized prospective trial, in my opinion, can't be looked to answer whether a robotic procedure is better or not. It'd be great if we could get that data, but it's very, very unlikely. Look how long it took us to get a randomized prospective trial to try and answer laparoscopic cholecystectomy. Let's see.
So you
I
did
think
that large database trial.
Say what?
You did the large database trial and you showed no superiority.
Well, but that's an early trial. We've got 8 months, and it did show a difference in the arena that I think is probably most important to demonstrate the power of robotics, and that is the group of specialists that went from open surgery to robotic laparoscopic surgery. And you know, that's the real power of this technology, is as an enabling technology to enable surgeons that maybe aren't laparoscopic surgeons to get there. It demonstrates the fact that the technology eventually will do the same for those of us who are laparoscopists, because you know, you guys said that laparoscopy is fine as it is. I would submit it is not. We can do much better than what we do now. And I guess my final point would be, Nat, I think your shoulder is worth at least $2 million. I might write the check myself to keep you from having to have any more rotator cuff operations if the Da Vinci could save the shoulder of Dr. Soper. So I'll leave it there.
Mark, that is absolutely kind of you, and I may take you up on that, actually. We also heard about the fact that cardiopulmonary bypass was really costly, but it also saves a bunch of lives. We heard that laparoscopic surgery was costly, but even in the early days, we knew that there were major improvements in terms of how patients did right around the time of surgery. I think that's very, very different. And some of the other things that, Rick, you were showing, they are all wonderful, and I hope that we can realize some of those things. But if you looked at the bottom of the slides, some of those photos were from 1998, 2002, 2005. There's been a lot of this stuff out there for a long time, but unfortunately we haven't seen it trickling back to what we can actually do today. And I'm not sure where those technologies are going to go, but it does kind of skip ahead of where we are in robotics, which is what we are trying to get at today.
I would make one other point, Nat, about the financial analysis from the medical center's point of view. At least in our medical center, the reason robotic prostatectomy is less profitable, the patients go home 3 days earlier, and the hospital can't make money on those inpatient admissions.
A few random thoughts.
Yes, please.
Okay. A few random thoughts that I would like to provide for you. First of all, I'm in violent agreement with Nat, and I was pleased to see that Scott was in violent agreement with me about the hope. I have found a couple of unintentional biases in the presentations of my colleagues. The biggest scientific bias that I see, depending upon evidence, requires that you have comparable subject groups. And I repeat this once again. The data that we have today that is comparing laparoscopic with robotic surgery normally compares those laparoscopic surgeons with thousands of procedures under their belts and 10 to 20 years of experience. They don't compare the early learning curve of laparoscopy, the first 7 years, with the early learning curve of robotic surgery. I find this scientifically reprehensible that we don't ensure that the quality of our experiment meets standards. Second of all, we're mentioning about why hasn't it gotten any better? Well, how long did it take us to get laparoscopic surgery? It began about 30 or 40 years ago, before we began doing our first laparoscopic cholecystectomy. So the technology development and transfer for laparoscopy was not 10 or 15 years like we have for robotics, but it was closer to 40 years along the way. And it was only the improvement of the camera that allowed it to get to the level that it is today. So we forget about the multiple years before, from the lenses and from the fiber optics and for the illumination that finally got to the state that we are today. Unfortunately, I'm not able to predict where robotic surgery will be at age 25 the way that laparoscopic surgery is, because we're only 7 years old here. FDA approved in 2005, and this is 2012. So I think it's just a tad disingenuous to be comparing 25 years of experience and their later successes with 7 years of experience and their early implementation. And finally, I would really like to invite my colleagues on the side to participate in a randomized study that has not been performed. I would like to be the experimental group, and I would like them to be the control group. And what we're going to do is we're going to jump out of an airplane. Mark and I will have parachutes, and they will not. And we will prove unequivocally that having a parachute when you jump out of an airplane is safer than not jumping out of an airplane. Thank you so much.
It's fun, right? Okay, Professor Scott Melvin.
I would agree that logical people would be able to identify which trials would require a randomized controlled trial and which wouldn't. Clearly, some of the surgery doesn't need randomized controlled trials, and however, some does. So these are one of the things that while it doesn't, we need to be able to show some benefit, some subjective benefit, some objective benefit, some kind of benefit, please. Secondly, it's true. It's absolutely true. Robotic surgery is in its infancy, and laparoscopic surgery is pretty well mature. So therefore, as I got that right, your conclusion is that we should continue on with inferior products while it's under development and just let our patients take the hit, let our healthcare system take the hit, and let the physicians take the hit in order to let this technology grow up. I'm not so sure I can agree with that, because in reality what happens is a lap chole done by someone who's well experienced is still pretty good comparison to robotic technology in its infancy. So it is fair to compare those as they exist today. We're not talking about 20 years down the road. Who knows what could happen?
Yes.
So, again, the premise of the debate is hope or hype. And in fact, I think what we're all saying, and my colleagues agree, is that there is great hope in this technology. I think my colleagues have pointed out effectively that this is still a very expensive technology, and I would submit that the medical marketplace is not an ideal capitalist environment. The device industry is perhaps a more ideal capitalist environment, and that's why your iPhone has amazing technology at far lower prices than your BlackBerry 10 years ago. The computer device world is obeying more unregulated laws of capitalism and is racing forward, and things are getting cheaper and cheaper. I think we can all agree that the medical marketplace is far more regulated and unusual in the way it behaves. And I think there will be a day when robotic technology becomes ever cheaper, like your cell phone has. We just aren't there yet.
Okay, question please. Oh, no microphone. Identify yourself and,
It's working now.
okay, indicate, excuse me, is this okay? Microphone okay?
Yes. So my name is Faik Jamali from Beirut, Lebanon, and I'd like to thank all the presenters for outstanding talks. And I'd like to suggest maybe a slightly different way of looking at this. The penetration rate of laparoscopic surgery or advanced laparoscopic procedures across the US, for example, if you look at colorectal procedures, is only about 20, and the best of estimates, 30% of cases being done laparoscopically. In an ideal world, it should be closer to 80% maybe. And the way that I would look at it is if we're trying to prove that the robot is as good as laparoscopy or better, it might be a wrong way to look at it. But if the robot maybe can allow the surgeons who are currently not capable of performing these advanced procedures to do so, then that's a major gain. So I would like the panelists to maybe answer or give me an opinion. Thank you.
Well, I think you're exactly right, and I think that the urology experience has been exactly that the robotic device was an enabling technology to allow them to do an operation that always was open in a more, in a less invasive way. My colleagues did point out the New England, I think it was the New England Journal article or JAMA article, one or the other, that questioned the outcomes across the board for robotic prostatectomy, but I think there are other trials that in expert hands show very good outcomes. So I think you're right that the right devices in the right hands may allow many more of our patients, both in general surgery and in other specialties, to enjoy the benefits of minimally invasive surgery.
Okay, next.
Hi, good evening. My name is Harry Miller, and I'm here in San Diego. And I've been an advocate of robotics in its early beginnings in '93. And it started here in San Diego with a product called ESOP and Dr. Jonathan Sakier and Dr. Satava. What concerns me a lot, because we do believe in robotics, is that the industry has manipulated some way, and some platforms that were already existing disappeared. Certain robots that were already existing, when these companies fused, now they have only one company, and a lot of things that were going very great, even though they had a surgery from France to New York or vice versa, which I didn't want to have myself, but it left a lot of ideas. And all these equipments and softwares like Socrates and Hermes that a lot of us know are disappearing. And if I'm a general surgeon, I don't want a Da Vinci, but maybe I want an ESOP to do a gallbladder and have a robot scope and move around inside the abdomen. So the thing is, a couple of years ago, we had a course in robotics, which we do down in TJ, and Computer Motions let us come up here to Goleta. And one of the surgeons is around 70 years old, and he had never touched a robot in his life, and he didn't go through laparoscopic training in his younger ages. And we sat down with this robot, and in a couple of minutes, he was doing intracorporeal nodding. So that was interesting for us. So I think this technology is, as I mentioned before, and I've seen other people who are a little bit older than me can benefit from this type of technology. Thank you.
Thank you. Are there any questions? Oh, please.
Hi, I am Vivek
Oh,
Bindal.
sorry. Where? Okay.
I am Vivek Bindal. I come from Delhi. I think all of the panelists agree that there is great hope in robotic surgery. As a young resident and fellow in training, we see hope in this type of surgery, and even those who presented against robotics, they are also agreeing to this fact. But the costs are prohibitive. So, but if the surgeons retract themselves from the technology saying that the costs are prohibitive and the evidence does not support it, so we will not apply this technology to our patients, then how will the technology develop? The engineers cannot alone develop the technology. It has to go hand in hand with the surgeons and the engineers in whatsoever companies they are researching it on. So I think we should continue to use the surgery in as vast applications as we can. More the surgeons use, more they get new ideas, and like how robotic prostatectomy, the Da Vinci system was not made for urology, it was not made for prostate, but because it was applied by a surgeon to his practice in urology, that Da Vinci prostatectomy has taken up, and now it is a standard of care at most of the centers to do a Da Vinci prostatectomy rather than open prostatectomy, and I don't think there is sufficient evidence to support this. So that may come out in general surgical procedures as well as other procedures, and we might be able to provide much better input to industry if we use the technology rather than not using it and just kind of discarding it as an expensive technology at the present. Thanks.
Let's go ahead.
Dmitry Olenikov, Omaha, Nebraska. I think what we need is a Steve Jobs of robotic surgery. And I suspect that if we look hard, there's probably many Steve Jobs of robotic surgery even here today. The problem is he's locked up in the jail of our current medical system, which is continuing to put him in solitary confinement. Perhaps once that's changed, then we can have that iPhone 4S with Siri in it as a robot.
Thank you. Yes, please. No, the other side. Yes.
I am Praveen Bhatia from New Delhi, India. I am surprised by the HOPE team that you have seen and showed us the evidence that robotics is definitely better. But we have not touched the area so-called access the inaccessible. Means that, for example, as it has been mentioned that the prostate, laparoscopically, it was a difficult proposition, and that is why people have been able to do it in a better manner with robotics. Similarly, thymectomies. If one has to go in for thymectomies, one has to take bilateral thoracoscopic approach, and if it is done by robotic method, then it is unilateral, maybe 3 ports only, and you are able to move around. So our thought process should be the access the inaccessible areas, and similarly access the inaccessible people, as our Canadian friend Mehran Anwari has shown, that it can be accessed for those people who are remotely situated, and robotics ultimately will help them. Any comments from the HOPE team?
Well, I agree. I mean, I particularly in terms of the areas of the body that are difficult to access. I think I see Dr. Horgan in one of the microphones. I think robotic esophagectomy is perhaps such an example where having the instruments and the visibility in the mediastinum can be a real advantage. So I think you're exactly right.
Okay. Next, please.
Yes, I think that you're trying to compare the impact of laparoscopic surgery in the early 90s with the impact of robotic surgery nowadays. And you're not considering the impact of in the patient care. When we saw the patients with a lap chole going home next day or performing now a lap chole as a same-day case, and the patient returned to work in maybe 2, 3, or 4 days, that's a big difference between laparoscopic approach with open surgery. But I don't see this impact in robotic surgery instead of laparoscopic surgery. The benefit of laparoscopic surgery was clear for the patient, for the hospital, and for the society. But this is not the difference between the robotic approach with laparoscopic approach. So we don't need to talk about the cost of robotics in terms of each surgery or the $2 million that costs each robot. We have to talk about what the impact in the patient, in the hospital stay, and in the society means. So we don't see now very much difference between laparoscopic and robotic in terms of the patient care. And if you think that it could be applied, for example, for a Whipple procedure, it's a very low incidence of these interventions done robotic, comparing with the thousands of lap collies we practice. I think it should be discussed in that terms. Of course, it's very important to develop investigation in terms of developing new tools for surgeons, for practice a better surgery. But I think we are still far away for that time. I would like to know your opinion in that terms.
Well, I think in many ways you've restated what you've heard up here. That is true for somebody who has a robotic laparoscopic prostate operation. They're going to leave the hospital 3 days earlier. They're going to have less pain. They're going to go back to work more quickly. There is at issue whether the outcomes are equivalent, better, or worse, and I think there'll be more data in that regard. So for that body of patients where a group of surgeons went from open to robotic and they had this enabling technology, they had exactly what you're describing. In general surgery, where we have a set of excellent laparoscopic surgeons, it's a different equation.
Okay. Say you.
I have a number of tweets and texts and so forth. I'm required to read a few of them to you. The first one had to do with a comment about, very interestingly, is robotic surgery the last level of Nintendo surgery because its predecessors were open and laparoscopic surgery? And is there anything after robotic surgery?
Rick, I would think you're the one who should answer that question. You're the one who was going way beyond where we are today to where we might be tomorrow.
Yeah, well, I think you nicely showed us that.
I think some of that has been...
I think you nicely showed us that answer.
Say again?
You already answered that quite nicely, I think.
Okay. The only thing is that you can't predict where the future is going to be, but you can kind of guide it if you embrace some of the newer technologies that are coming forward.
I would say the answer to that is yes. I mean, there are great similarities between a video game with your, with the controller in your hands away from where the action is on the screen. That's very much like the robotic experience. And I think it will be interesting to see the next generation of young people and residents come through their training and see how they respond, because I know my 20-year-old kids are exceedingly comfortable with that model of manipulating things.
There was another a couple of questions about was laparoscopic surgery more costly when it was first started? I don't think the cost should be considered in robotics this early in its lifetime. Any comments about that question?
I'm sorry, there shouldn't be any discussion of cost, what?
I think the intent here was that because this is the early learning phase of robotic surgery, should there be that much of an emphasis on cost in something that is just an emerging technology as opposed to one that's an established technology?
Well, again, it's been around for more than a decade, number one. Number two, we are in very different economic conditions in this country for medical care today than we were a decade ago. And as has been mentioned several times, the delta between the existing technology and outcomes between open and laparoscopic is much, much different than the delta between laparoscopic and robotic laparoscopic. That, again, when you put it into the whole cost equation, I mean, my thesis is at this point in time with this robotic technology, with this monopoly of the market, it is really hype. I do agree that we need to have people who are investigating the further consequences of the information age, what else can be done, and get competition on the market. And then I think there would be all kinds of reasons and all kinds of hope for where we should be going with this technology.
Let me just make one additional comment sort of related to that. If you take your mind out of our current construct of of the Da Vinci system and general surgery, Think about eye surgery. I don't know how many people in the audience have had refractive surgery. I have not, obviously. I'm wearing my glasses. I've talked to a lot of people who have. That is a robotic operation. It takes, I don't know, 3.5 minutes. The little cup goes on your eye. Your cornea gets incised. It gets reshaped. Boom. It's quick. It's effective. And it's a model that's been quite, people have made a lot of money with. So I think there are examples, even in medicine, of robotics where the hype or the hope has been completely fulfilled. And again, those are things that no surgeon with their fingers could do as well as that robotic computer does.
We have a couple more tweets and texts here. Here's one. So, are you going to do robotic surgery after the evidence shows that it is more effective than laparoscopic surgery? Or will you continue to do laparoscopic surgery even though the effectiveness is not, the laparoscopic is not as effective as the robotic?
Well, that question, I would say, is loaded with hype, frankly. But if we could prove that robotic is better for the things that I do, and if I could convince my hospital to make access to the robot available, absolutely, I would switch over to that.
Just reporting what's on the tweets here. I had a question for you, though. Would you do robotic surgery if it was free? Because if you're not even going to do the surgical procedure, if it's for free, then it's the end of the debate.
No, I wouldn't do it for free. I wouldn't do it if it cost nothing. I think I would do the thing, and I would do it regardless of cost if I could demonstrate benefit to the patient, objective evidence, even subjective evidence that showed a significant difference. We can all say we like it better. And if it doesn't hurt the patient, then I suppose it's okay. Cost doesn't make a huge difference, but I think as a matter of our public health system and our overall health of the society, we have to be judicious in our use of rare resources. Santi.
Okay, please.
My name is Fahad Arfati from Chicago. I would like to thank you for this great debate. Actually, this topic is very important for me since I am a new medical school graduate and the future of surgery is still in front of me. And I'm sure after 5 or 10 years, the robotic will be one of the options. So I have two concerns. The first one is that when you are sitting behind your robotic, the Da Vinci, and how this make a difference between, how this going to affect your teaching for the resident or for the students who usually when you interact with them during laparoscopic surgery or open surgery, you have face-to-face, you communicate by eyes, you communicate by hands. But when you are sitting behind the Da Vinci, how this is going to affect the teaching and the rapport between you and the resident. The second concern is, let's say you are doing a robotic for cholecystectomy and suddenly you injure the hepatic artery and you couldn't control it by the robotic. How long does it take you to move and open the patients to fix it? Thank you.
So I'll answer that.
Yes.
For training, I think you bring up a good point, and that was a big concern earlier. There's good data now that suggests that skills training is important. Skills training works. Hands-on and supervisory roles in surgery work. The new module is a driver's ed type thing that allows shared resources. So the education has come along, and I don't know that that's a barrier to adoption. Barrier to surgical emergencies is not a significant concern. An experienced team can get the robot out of the way pretty quick and get things under control that can't be controlled robotically, which often it can. So, thanks.
I think actually what perhaps was a barrier is now going to be an advantage because there now are great simulators that hang on the side of the Da Vinci, making that immersive experience now a training experience for residents. You know, the world of training residents is going to undergo a revolution as well. And I think, you know, more and more there's going to be teaching and training not in patients but in simulation models. And the Da Vinci is ideally suited to do that because it is such an immersive experience. Other robotic systems may not have that, but this particular system does.
Okay. please.
Santiago Horgan, UCSD. I know my chairman doesn't need any lawyers, but Scott, two comments and one question. First comment is the robot did change since 1999 to 2012. We have 3 generations later, and we have a single-site platform, so there has been a change. And the second is the Ara Darcy paper that you quoted, if you read it from a different angle, does show an improvement with robotic surgery and 2 days of hospital stays a lot. But my question to you is, don't you feel that robotic surgery is proving to be an enabling technology for operations that today, exactly 22 years after the first laparoscopic cholecystectomy, are we still doing open? 99% of the esophagectomies worldwide are done open. 99% of the liver resections worldwide are done open, and 99% of the Whipples are done open. And they are done open because I believe people don't have the skills to do it. And the same way that if we didn't have a robot, 99% of the prostates will be done open today. So I think that this is a hope for an operation to enable those surgeries to be done laparoscopic. What is your feeling?
Well, laparoscopic prostatectomy probably wouldn't be being done if there was no robot. It's an operation that was designed for the robot and done with the robot, and without the robot, it wouldn't be being done. One can argue the outcomes superiority versus other therapies for prostate cancer. Most of the data, as you point out, some of which you've written, some of which we've written together, would not show significant superiority in general surgery procedures, in length of stay, in patient satisfaction, or clinical outcomes, no matter which way you read that. And what was your first question?
What about the operations that we are still
So
doing
all
open?
the low penetrance operations, those are still difficult operations that get done in many situations by low volume providers that are going to be difficult operations in anybody's hands. It's true that the robot can add as an enabling technology those tools. However, we've yet to show a benefit, and those are low volume cases, so you're going with the assumption that the robot is going to be better than an open surgery for pancreatic duodenectomy, and we just don't know that yet, even in the high volume centers. Maybe. Keep working on it. There's a place for research, but let's call research the way it is, and let's not call it standard clinical care.
Okay, please.
Hello, my name is Emilio Ruiz. I'm coming from Milan, Italy. And I am leading a research group developing a new concept of tele-manipulated surgery. Not robotic, because it has not been designed for making automated interventions or with some artificial intelligence. I believe that the current system Da Vinci neither has these capabilities. So we designed the system as a progression of laparoscopy toward something new, something that brings several advantages. And I just wanted to let you know that new approaches exist, that other people think in another way. And in particular, our ambition is the one of giving a tool that allows surgeons to get trained in laparoscopy, but at the same time to do something more than what is capable in laparoscopy. So I think that there are advantages, and we already had some confidence about preclinical studies about that concerning the operative time. So we saw that putting the surgeon in ergonomic posture and with laparoscopic tools allows him to work faster and to spare time during the intervention, up to 40%. So this is quite an interesting figure, and I just wanted to let you know that we are working with a different concept, and that there are other ways of doing telemanipulated surgery. Thank you.
Thank you. Yes, please.
I'm Dr. Ali. I'm from New Delhi. I have a small question. Regarding the training of postgraduate, as somebody asked here, should we directly go to robotic training, or should we go via laparoscopic training? I mean, how far robotic is going to replace laparoscopy? What is your comment in that? Should we go through laparoscopy or directly to robotic surgery?
Well, I would think at this point in time, if you're interested in general surgery or GI surgery, the laparoscopic skill set can only help you. So I think that is a building block for anything else. Now, the reality is our trainees need to learn open surgery. For many operations, they only know how to do it laparoscopically, and we're trying to think of ways of retraining and remedial open surgery simulation labs and that sort of thing. So I think all of these technologies, robots, laparoscopy, whatever, are just technical ways of doing things. It's a matter of learning the concepts of the operations that need to be done and then applying the technology to be able to do it in whatever way is best. Depending on your situation. Delhi may be very different from Chicago in terms of what is available and what is expected. So I think we as trainers of the next generation need to be able to offer multiple different venues for training. That's my own opinion. I don't know if, Mark, if you have other thoughts, or Rick.
Well, I think you bring up a very good point. I know the urologists in our training program are not learning laparoscopic prostatectomy. They're learning robotic prostatectomy. Nobody is saying to them, you know, you need to learn, figure out how to do this with the laparoscope. So once they've tasted that enabling technology, I don't think they're going to go back. General surgery is in a different situation again, because we, I believe, are committed as a profession to driving ever more minimally invasive procedures into our residency training programs. But for us, that's more likely to be laparoscopic than robotic, obviously, for all the reasons that we've described.
Thank you very much.
Okay, you're.
Yes, my name is Young Kim from Seoul, Korea. So for me, I think that the only cost is a problem for robotic surgery, because from my experience for the gastrectomy, we have performed 200 gastrectomy. At the first stage, it was somewhat difficult and they have some complications, but now I feel that the robotic gastrectomy is superior to the laparoscopy gastrectomy. But the only problem is cost. So I'm very curious why monopoly is continuing. I think the technology out there is enough to develop robotic. Isn't it true? I'd like to ask to Dr. Satava why it is continuing. Why can't we make other competitors to make robotic systems?
Thank you. There are a number of issues behind this, and it's not quite as simple as it would seem. For example, it takes a long time to develop a robotic system. Very expensive, like CT and MRI scans we have now, but there was a monopoly on CT scans when they first came out. This happens in almost every technology. Now, I'm not 100% pleased that we have what appears to be a monopoly, but there are some advantages to having a single system that's fully integrated and that you're able to ensure the quality on. One of the problems that we have as we start developing other systems is that they don't meet the rigor that something like the Da Vinci system would have at this point in time. They may in the future, and so we're going to have to go through the same processes that we had before. The second component is a simple business fact. When you spend an awful lot of money and develop something new, and then somebody comes right behind you with no development cost relative to what you've been, it's very, very difficult. And to that end, that's why in the United States we have intellectual property protection and patents. And so they are beginning to expire, and we will be seeing new systems coming on board. And quite frankly, over the past 8 or 10 years, I've only seen 1 or 2 systems, and they were nowhere near developed as far along the line as the Da Vinci system had been. And so to that point, yes, it may appear that we've got a monopoly, but I'm rather convinced that in the not-too-distant future, with the systems that have finally been able to go through the rigorous process of not only discovery, but also of prototype and then finally coming towards a commercialization stage, that we will see some competition come. But it's never been an equal playing field. When the Model T Ford that I showed you to begin with came out, it was 23 years before there was another company that actually was able to come out and develop a different automobile. It just has to do with technology development and technology transfer. So I agree with you that I'm concerned that there is the appearance of a monopoly, and there is to a certain extent a little bit. But my view is that we will, in the not-too-distant future, seeing the emergence of other technologies that will be able to be competitive with them. I'd like to just make a comment about the robotic system that we have been hearing about back and forth on this, and it's very interesting, is that the other technologies are not going to go away. We're not going to get rid of open surgery. We're not going to get rid of laparoscopic surgery. We're not going to get rid of cells, and we're not going to get rid of robotics. What we normally have is a shifting of niches. And there may be more in a particular field done robotically than laparoscopic, but in a different area, you'll have more laparoscopic than robotic. I don't have any fear that any of these are going away. It's not a zero-sum game. Either you do this one or that one, and the other one goes away. It's just a shifting of how much of each one that you end up doing.
Okay, now we're going to take some more webcast question.
Yeah, we have another one, very, very interesting, and I'd like to hear the responses from my colleagues there, is, do you feel the direct marketing of robotic procedures by hospitals to patients is unethical? Recalling the initial experience with laparoscopic surgery.
Well, so I don't know about unethical. It's certainly distasteful. But you know, we're just in a different era. A generation ago, we also didn't market drugs directly to patients, and I find that at least equally distasteful. So we're in a different era in terms of marketing, and I would love that genie to go back in the bottle, but it's not back in the bottle, and that's the playing field that we're all on. So my guess is we're all going to continue to market.
Yeah, I would agree with that as well on both counts. What I do object to, though, is when there is hype in those advertisements that do claim superiority to the robotic approach or whatever, when that data is clearly lacking. And you might even talk about the, 1-800-GET-THIN or whatever, and the claims that have been made with that one as well. So I think there are lots of questionable areas in marketing, and I totally agree that it's very akin to the direct-to-consumer marketing of drugs, which I just think is crazy.
Do you have more webcast questions?
A recent one that just came up was, will robotics go to microendoscopic procedures? And the answer to that is clearly yes. That's a direction that all of medical science is heading. Not the only direction, but one of the major directions that are new, going down to the micro level as opposed to staying at the macro level, the world that we live in. We've built tools, whether they be robots or imaging technologies, that allow us to see and do things that we've never been able to do before. The comparison I make is the invention of the telescope or the microscope, allowing us to see things that our own body has never been able to see before. So it's definitely going to go down on that. The questions are, which are going to be the procedures that are going to have value when we do that?
Okay. Okay. Let's go ahead.
Hi, Mala Thenapin from Wisconsin. The delta in laparoscopic surgery was shorter length of stay, faster recovery. Don't you think that delta with robotics is the information? If the technology can move in the direction such that we can see the cancer cells and make sure that we can get a negative margin, doesn't that make us a better surgeon?
That certainly has the potential. That's one of the hopes that I think we have for our new technology. Right now, none of that exists, or it's not been well clinically validated. So that's just an added technology that would provide a significant benefit if and when we hope we have that technology. Thank you.
And if it was an imaging technology, there's no reason why that couldn't be layered onto a laparoscope as easily as onto the Da Vinci system.
There are a few more tweets and texts, and I know there are people out there, but the hour is getting late, and some of them that we're hearing were becoming repetitive. So I think that we should thank those in our audience and those who've been tweeting us and texting us. Appreciate your comments and your questions to us. And I'll turn it back to Dr. Yamamoto so he can close the session today. Thank you for your participation.
Thank you very much. So now time for the judgment. Okay? And if, clap your hands. The sound is better than raising your hands. So robotic surgery is hope. Okay, very good. And robotic surgery is hype. Okay, I judge. Robotic surgery is hope. Thank you very much and have enjoyed the night. And please come to the Midway. There is an official reception tonight, including International Musical Surgeon Sing-Off. So have enjoyed your night. Thank you very much.